that we're really excited to be here talking about our favourite subject, TMD, occlusion, bruxism and spleens. And Tim's in charge of flicking the slides, so you'll need
I'm in charge of flicking the slides. Hey everyone, great to be here tonight on the sofa or in the kitchen chair or whatever it might be. Sarah, introduce yourself.
Are you going to change the slide?
Yeah. Have you got your slide of you up there? Can you see it?
No, I must be on a lag. Okay, so my name's Sarah Beach. I'm an advanced scope oral health therapist up here in sunny Brisbane. But I've got a background. I was a dental therapist, graduated back in the 90s, and then I went on. I've done a couple of other degrees in public health, communication and media management, and also the academic upgrade to become an OHT. And I've done a lot of study in more recent years in orofacial myofunctional therapy and collaborated with many people around the world, including Sandra Colson and Larry Kotlow and the Breathe Institute. So that's my little bit of background.
Awesome. So is the screen working?
It's stuck.
Can you see?
No, it's stuck.
Oh, someone, I don't know if someone can share with Tabitha or somehow share with us, just make sure that you're actually seeing. Tabitha, is it working fine?
No, I can only see your front page.
Yeah, it's not moving.
Okay, sharing is paused. Resume share. Let's try that. And
so also just for context, share. Tim lives in Melbourne, so when we're trying to collaborate on these things, it can be a little bit complex.
I'm going to stop share and do the share again because I don't know why it's not working.
Thank you. Sorry.
Yeah. That's all right. How are we now?
Yes. Well, you missed a slide.
Okay. Yeah. All right. Let's go. So
I think it's you.
Awesome.
Okay.
I don't know why it froze. That's what Sarah was talking about when she was talking. That's their little slide with their beautiful children.
Yeah.
Talking blindly. And as for me, I practiced myotherapy. Myotherapy is perhaps originated as like a cross between remedial soft tissue work and physiotherapy. It's probably the simplest way to describe it. And myotherapy specializes in treating chronic musculoskeletal presentations. And so over the last 20 plus years, I've had a special interest in cervicogenic headaches and TMJ, and they're often connected. And so when I also train other therapists online, and through that online exposure, I was reached out to by a lady in Brisbane named Sarah Beach, and she asked if she could learn the muscle techniques and the relationship between muscles and TMJ pain, which the majority of TMJ presentations are neuromuscular. And so she asked if I did a course on just this area. And I said, no. So she invited me into the world of oromyofunctional therapy. I since then did some training with Sandy Colson as well, and have then spent a lot of time with Sarah collaborating and working out the relationship between what physical therapy is fast and simple that people in the oral health field can utilize, and what knowledge can they utilize that has been kind of bread and butter knowledge for me for years. And so that's kind of our story. And since we've developed this kind of training, we've delivered it in many places in the United States face-to-face, and now our online version of this course is available internationally, and we've got people all over the globe who are learning from it. So we've had a lot of connection with many leading figures and institutes in this area. We collaborate closely with the Breathe Institute in LA, and I won't go through all of those, but we have either collaborated with or run courses with or attended courses of all of these people and organizations. The link that Tabitha will give you will send you to a page It should be fastandfunctional.com/TMD-online. Now, on that page, we've deliberately put heaps of content. So if you are interested in learning more about this kind of stuff, you can watch demo videos. There's really clear explanation of what all the modules contain. And so you have a really solid picture of what you will get out of this kind of 8+ hours of training, which really, to sum it all up, will give you the latest evidence-based thinking around TMJ and TMD presentations and how to quickly and easily differentially diagnose those presentations in your clinic, and then some skills to be able to treat them yourself, or at least being able to know who you need to refer to. And it's been a hit. It's been very, very popular. And we're, I don't know if Sarah, you want to speak to that, but we're really excited about the fact that practitioners use it, use the knowledge and use the skills. And it's really the testimonials that we get back, and we get a lot of them, is really from therapists who use it. So it's nice to do something for CPD, but we're really not that interested in that. We're really interested in you helping people. And so that's, we've got orthodontists, a lot of myofunctional therapists and oral health therapists of varying descriptions, as well as TMJ specialist dentists, etc., who have all benefited a lot.
Yeah, the interesting thing is the course has attracted a lot of TMD specialists. So when we were over in the US particularly, we'd have a lot of TMD trained dentists come to the course. People are, are always learning, always seeking better ways, more comprehensive ways to manage these patients. And I think, I think what we cover in our course really kind of gives you a really broad overview and really good tools to get out there and start working with these patients straight away. Both Tim and I now collaborate with oral and maxillofacial surgeons, and it really is just such an integral part of their management of these TMD patients. So it's an exciting space to be in, particularly for those who are dental practitioners who have studied myofunctional therapy. That's how I came into this whole area, and this is where I saw this massive hole and connected with Tim to go, hey, there's more to this. It's not a one-trick pony. And so it's a really exciting space that we want to share with you guys.
And the reality is, I don't want to offend everyone, but TMD, as far as a musculoskeletal pain complaint, is an over-serviced industry. People invest in far too much treatment and spend far too much money sooner than they need to. Whereas some simple advice, some education, and maybe some simple techniques are, in many cases, all these patients need. So I had a new patient this week who has been getting Botox regularly. The only reason for her TMJ pain, the only reason she came to me for treatment was A, because her husband was a friend of mine, and B, because she's pregnant and can't get the Botox while she's pregnant. And so she thought, she'll give it a go. After about 3 minutes of the right treatment, her pain was gone. And I just thought, why spend the amount of money that you can spend on Botox? Not to mention the fact that it's a neurotoxin that you're injecting into your body and all the other harmful effects of it. I'm not 100% against Botox, just about 90%. But, when it's not necessary. Anyway, let's not ramble. Let's get on with it. What's the problem? Why are we here? Sarah.
So temporomandibular disorders, 10 to 20% of the general population have TMD and orofacial pain symptoms, but only 7% will seek treatment. It's the second most common pain after toothache a dental practitioner will be presented with if they ask the right questions. And you'll hear us bang on a lot about asking the right questions and listening to your patients. It can be associated with other pains, such as headache and neck pain. Usually people affected by TMD are between 20 and 40 years of age. And lucky for us, it's more common in females than males.
And something I failed to mention earlier was the fact that we're deliberately going to try and limit this to about 40 minutes and open it up for questions. So I believe Tabitha can take questions as we go. She might find that several of them are answered along the way anyway. But then, yeah, you can forward your questions to her, and we'll jump into some questions towards the end. So this particular talk, we want to talk about bruxism, splints, and occlusion, and their relationship to TMD and what the latest research is showing us. So I got Sarah while she was on the airplane to, you know, think about all the contributing factors to TMD, and needless to say, this was what she came up with. So
it's a torn vomit bag from the plane. I had no paper, so I had to write on that.
So buckle up, people, because we're going to spend the next hour sitting here and unpacking this really awkward diagram.
Yeah, but can I just say, I mean, this is the mess that is TMD. There's a lot to it. And you can see over on my left, I put splints in that little box, because in dentistry, we're always focusing on the mechanical, the cracked tooth, the perfect occlusion. Oh, let's fix it with a splint. But, you know, it's actually just one little facet to all this other stuff that's going on. And this is why it's so important to educate yourself in this space, to educate yourself in asking the right questions, listening for the right answers. And there's so much we can do as clinicians ourselves to help fix these patients. Yeah. So this is not, yes, it's a multidisciplinary approach, but there's so much we can do as individual practitioners to make a huge difference in these patients' lives.
Yeah, 100%. So what we feel like we've succeeded in, and certainly based on the feedback that we've received from so many that have done the course, is that we've made it simple. And so, yes, it is complicated, but here is how you address the one or two things that are going to 70% of the time get a really good outcome. Like, these are the simple, and they're often very simple things that are just missed. Even when people get all the way down the line to the maxillofacial surgeon, as Sarah and I both work with maxillofacial surgeons, we see it all the time. They get all the way down the line. They've been through the GP, they've been through the dentist, they've been through 3 physios and an osteopath, and then they get to maxillofacial surgeon, and
guess what happens?
And it's like, wow, it's something really simple.
Well, you know, I was talking to the 2 max faxers I work with, and they said it's probably 5% of the cases that they actually have a surgical intervention for. The other 95%, guess what they say? Go and get some conservative management. So, and these patients are so frustrated because they say, I just told you all my years of history. I've just told you I've been to all these things. And, you know, what do we do now? And that's why they've brought me in. And that's why Tim also works with the Max Fax, because we can go in there and manage these patients, you know, more comprehensively, I guess, with this approach that we're going to be talking to you about.
All right. So let us unpack for you. Let me give you the 5-minute version of the 8-hour course. Okay. Here's how you, here's the simplest answer that we can give you in a short period of time. And let me go through it for 5 minutes, and then we'll give you the answer at the beginning, basically, and then we'll unpack a little bit of the research on bruxism, the research on occlusion, and the research on splints. So this is perhaps the simplest thing that you can learn, is the fact that 99% of TMJ presentations are either going to be acute or chronic myofascial, which is muscular, or they're going to be maybe 15% of them are going to be really complex with multiple factors. The acute type of TMD is where the pain is arising primarily from the retrodiscal tissues, which is this posterior here. You see it being squashed by the condyle. Here's the disc. So this is an anterior disc displacement with reduction. And this type of, if the pain is directly arising from the joint, it will be sharp and localized, like knife-like pain. And that's all you need to know. That's all you need to know. But what you also need to know is that only a small percentage of patients have that type of pain. So let's say 80% of patients are prescribed anti-inflammatories, but only 20% of patients have inflammatory articular pain, especially chronic TMD patients. It's rarely inflammatory pain. So that's the first big takeaway, okay? The second is muscular pain. Now, the majority of chronic or pain that's gone on for more than, say, 6 to 12 weeks TMD presentations, their pain, whether they have restriction in opening or no restriction in opening, is likely to be muscular. And so that's called myofascial pain. And there's been some great research done by Janet Travell and David Simons, where they've charted pain referred from masticatory muscles. And if you know these pain patterns well, whenever you have a patient that presents with TMJ, long-term TMJ pain, you will almost certainly be able to identify one of these pain patterns from temporalis or masseter or medial lateral pterygoid are your main offenders. And as you could see from those diagrams, where the cause is in the muscle is not where the pain is. So it's really valuable to have thinking about the muscular source, which is, again, 70% of TMJ presentations, roughly, is arising from skeletal muscle. I'm just going to turn off my little sound thing. Can you still hear me talking, Sarah?
Yeah.
Okay.
Don't mute yourself.
So, all right. Myofascial restrictions can also be the sole cause of asymmetry and TMJ pain. So asymmetry in jaw movement. So here's just a little example of a gentleman who presented with restriction or asymmetry in his opening and long-term TMJ pain that we did about 5 or 6 treatments with. He's much better now. That's how he presented at first. And if you just want to have another look at that, I'll just see if it'll come up again. So I'm just jumping through this. But after just a few minutes of muscular work, especially on medial pterygoid, it changed from this is the initial presentation, and then what you saw was the following the treatment. So asymmetry is very often purely muscular condition, not just the pain. Here's another patient who presented to me with long-term TMJ pain, and you can see after 1 treatment and 1 week of myofunctional retraining, some homework, some exercises, some tongue exercises, and some jaw exercises, that was the improvement. It doesn't mean all of her pain went away instantly, but once she had much more symmetry and much more function, it's going a long way towards getting better. And they're very common scenarios, very common. And finally, the third categorization, to make this as simple as we can, is those complex multifactorial cases where a patient's condition is tied in with anxiety as a driver, bruxing as a contributing factor, poor sleep quality, poor airway, etc., etc., etc. There are many potential contributing factors, and sometimes we've got to work through them one by one in order to help patients like this get over their pain. But this is a small percentage of TMD presentations. It's maybe 15%. And so therefore, the biggest take home that we're going to keep banging on about, as Sarah said, is the foundation for successful treatment of any chronic condition is listen to your patient. If you can figure out which of those 3 categories they're likely to fit into, then you just know what you're doing next. And Sarah and I sat down and discussed this, and we thought, if we're going to give just 2 simple and commonly overlooked pieces of education for patients with TMJ pain, what advice would we give them? And these are the 2 biggest, quite simply. Your rear molars should not be in contact at rest. Your front molar, your front incisors are allowed to be touching, and preferably your tongue should be on the roof of your mouth. And so it's amazing how far patients get down the line with the number of consults they've had, and no one told them this. They thought it was normal for those rear molars to be in contact at rest. So one of the simplest and first things that you can tell people is that, and another is movement is good for you. Now that might sound really simple as well, but when a patient has had pain in a joint, and this goes for a knee or a back or an elbow, they will develop some avoidance behaviors. So they'll stop using that limb, or they'll stop using that joint. So with the jaw, they'll stop moving it. Sometimes chronic long-term TMD sufferers, you'll see them, they won't move their mouth at all. Like they just won't move that jaw. And yet ultimately, the only long-term fix is going to be more function and more movement, not less. And so that doesn't mean give them 1,000 exercises in week one, but it does mean that's where you're going with them. And sometimes psychologically, just for them to understand the fact that it clicks or grinds is okay. I'm allowed to move it, or the fact that it's uncomfortable to open it fully. It's safe, like it's okay. You're very unlikely to cause any further damage or make the thing worse, because people get in their heads that they're wearing it out. They just get these pictures in their minds of bone on bone and that type of thing. The silly thing is that even patients with advanced degenerative osteoarthritis, where they literally have no disc and they have bone on bone, in many of those cases, they have no pain. So the final bit of homework that or takeaway that we want to give you, and we'll unpack this later in the night, is a very simple exercise that you can prescribe for patients who are, particularly those patients in the chronic case. And so that's the answer before we start.
And we've got a little video of that beaching on YouTube as well, because I got sick of talking my patients through it all the time. So I send them the link to it on YouTube that explains. It's got a little excerpt from our course to explain that exercise, but it covers both postural, airway, breathing. It's a nice combination of homework for them to do. So occlusion, when we look at, I don't know about all you guys, but I've been looking at mouths for, nearly 30 years. And when we look at natural dentitions, we rarely see the perfect occlusion. So the textbook class 1 occlusion rarely exists, particularly these days. Yet when we have a patient present with TMD, we suddenly want to rehabilitate a dentition to achieve a perfect occlusion. So this is where one of the schools of thought of rehabilitating the occlusion will fix TMD. So this paper here that we've got up by Manfredini was a literature review of 25 papers looking at whether or not there is an association between features of dental occlusion and TMD. And the findings were consistently towards a lack of clinical relevant associations between TMD and occlusion. So, so it's an old school of thought that's kind of been thrown out the window now to stop rehabilitating occlusions to fix TMD. However, we don't want to throw the baby out with the bathwater, because occlusion or, an imbalance in occlusion can act as a trigger. So, as we start to unfold these things, you'll see, and you saw from my messy bit of paper, occlusion can be one part of that picture. So if you've gone to the dentist, you've had a filling, you've got a high spot, and that's the straw that broke the camel's back and throws you into TMD. I've seen plenty of cases like that. Tim's seen plenty of cases like that. So
this is really similar to what we're learning in the physical therapy world. So what is now common knowledge, actually, in literally the last 5 to 10 years, is they've done enough research to figure out that there is no causative relationship between the degree of degenerative change that we can see in joints in the spine, for example, and the amount of pain that a person has. So this is true for mechanical structures like the joint, the TM joint. It's true for mechanical structures like the way the teeth meet and how that causes the jaw to sit. And so the prevailing, both in the physical therapy world and in the dental world, it's kind of always been this assumption that if I do an MRI or an X-ray of your lower back and I can see degenerative disc changes and maybe in some cases, some really obvious degenerative changes. The simplest way is to describe a patient that I saw when I was very early on practicing myotherapy. She came in with with back pain and her scans, and she was in her 70s, and her lower back X-ray looked horrific. Like it was a massive scoliosis in the lumbar component with very advanced degenerative change, huge lipping and osteophytes everywhere on that spine, and severe disc narrowing. It really looked bad, and I thought to myself, I don't know if I'm going to have any success here. But I worked on the muscles around that spine. I worked in her lower back, and I gave her a little bit of instruction about improving her gait quality, her walking quality. And she came back the next week and said her back's 100%, absolutely fine, no pain whatsoever. And I thought, I wonder how long that will last. Is that a placebo? Like, what's going on here? And when I saw the same thing occur again and again and again, this is 20 plus years ago, I realized that there's actually no real correlation between just how bad, in most cases, there are exceptions, but in most cases, just how bad the structure appears and whether the patient's got pain or not. And you can apply exactly the same idea to occlusion. So there's been a strong emphasis on the fact that if we can get the teeth to meet perfectly, and there's old schools of thought with spine, if we can get the spine to align perfectly, the pain and everything will be gone. But we see spines that are perfect and can't find anything wrong with them. They're symmetrical, the disc spaces are nice, and the patient has chronic pain. We see patients with very good occlusion and they have chronic TMD pain. We see patients with terrible occlusion and they have no pain whatsoever. We see patients with terrible spinal degenerative change, no pain whatsoever. And so the causative relationship is gone. Like, that's old history. In fact, this paper that Manfredini puts out there suggests, he calls the paper, is it the end of an era? So is it the end of a way of thinking? And he's right on target. Now, Sarah said there is an exception. So there is an exception. And I remember sitting in the US chatting to someone who was the head of something really important that I can't remember who it was. Sarah knows. And she was saying, but we all know that if you have a single tooth that's like 0.5 mil of premature contact, that it can trigger TMD. Now, she's kind of right and she's kind of wrong. So she's right for some people. So if a patient has a history of high anxiety, poor sleep quality, maybe poor airway, maybe even a history of some clicking in the jaw, in the TM joint, and a nervous disposition, and then they get a procedure and that occlusion, there's a premature contact because the dentist didn't quite get the occlusion right. It's the last piece of the puzzle. It's the last offending threat that the brain receives that triggers a cascade of symptoms. And so the patient will get pain, often nowhere near the tooth, but headaches or neck pain or jaw pain, ear pain, all that kind of stuff, which is really the brain getting to a point of a threshold where there's simply too many factors, too many threats. Now, when I say threat, there's psychological threats, there's like anxiety, and there's emotional threats, there's environmental threats, there's the biology of the joint itself as threat. And the brain takes all of this information in and scrutinizes it and decides whether to cause pain or not. And so sometimes, and that's a summary of pain science 101, in the last 10 years. Sometimes that premature contact, that occlusive contact, is the straw that breaks the camel's back and triggers the TMD. So there can be a relationship in that respect.
And she was the president of the American Craniofacial Pain Association, Tim.
Okay. Got it.
Just someone important. Yeah.
Good. Okay.
Yeah.
So let's keep moving. If I can press the right buttons. So we're going to tell you very simply that if you want some practical take-home advice, it's listen to your patient and ask them questions. Because if you have that patient who is triggered by the premature contact, sure, go in and fix their premature contact. But ask them a bunch of questions, just some lifestyle questions. How do you sleep? Consider their craniofacial development, whether you think, or even their tongue restriction, whether you think there might be some airway problems going on here. Are you on any anxiety medication, et cetera, and consider the whole patient rather than just the problem. And ask them this question at rest: do you hold your rear teeth together? Are you not meant to do that? Is often the response you'll get. And if they're a very anxious and apprehensive person with this pain, they might have stopped moving their mouth. And so encourage them that movement is good for you and heat is good for you.
Yes. So bruxism, another topical subject. So bruxism and TMD, how do they connect? Do they connect? We've got two types of bruxism. We've got awake bruxism and sleep bruxism. So awake bruxism is actually has a higher reported incidence than sleep bruxism. However, is that really correct? Is it reported more because they are actually awake? And for the sleep bruxism, you really need data from sleep studies. So, who knows whether or not there is a higher incidence of awake. The awake bruxism is correlated with anxiety. So it does link into nervous disorders, panic disorders, anxiety disorders, but it can affect anyone having daytime bruxism. You might know yourself when you're in the middle of doing a filling, you might posture your mandible in a funny way. I've seen plenty of people do that over the years. So you really need to screen everybody. Exactly what Tim said. At rest, do your back teeth touch together? People think it's normal. I used to think it's normal, but it's not. And as a TMD sufferer myself, let me tell you, it's life-changing when you stop contacting your rear molars. So like Tim said, we've got to create awareness. We've got to educate these patients to have a mantra of lips together, teeth slightly apart. I tell them just a hair's breadth apart. And for those of you who are familiar with myofunctional therapy, that's where these principles marry so beautifully. So tongue resting on the palate, lips together, teeth slightly apart. If you do that and you have a reminder system, and I'm not talking a reminder system, there's apps out there, bruxism apps and everything, but just creating awareness of the context in which people brux during the day is often enough to get them to break the habit, particularly if they're coupled with some myofunctional therapy exercises. So with daytime bruxism, it's the answer is not an appliance in the first instance. Okay, that is not initial therapy. Initial therapy should be education, counselling, awareness. And then there is a minority who may need a habit breaker during the day for short term down the track, which a dentist can make. But yeah, then you've got sleep bruxism, which is obviously more complex because you need a sleep study, and there's a whole gamut of sleep medicine education that you kind of need to understand that story. It's basically during the day, daytime bruxism, you kind of, protruding the jaw. Sleep bruxism can be all over the place. So you can do a lot of damage to the teeth, which leads us on to, does bruxism cause TMD? And this, Tim can tell you a little bit about the study, and then I'll tell you a little bit about my story and bruxism.
Yeah, so once again, one of the leading researchers is a guy in Italy named Daniele Manfredini, who is kind of leading the way in researching as far as just objectively pulling all the research papers together and trying to determine what does the evidence actually say in the research papers. And part of the problem, of course, is that splints are a good way to make money. I mean, I don't know if I'm allowed to say that in this forum, but they're convenient, they're easy, they're fast. And so we'll get to splints in a minute, and also more importantly, bruxing is a convenient answer also for patients. The reality is that the majority of people that brux don't have TMD, and night brux. And so what we've found for patients, so this paper, to summarize this paper, they found that there's a very high correlation between TMD and bruxing, nocturnal bruxing. 80-something% of TMD sufferers would brux at night, but they found that there's not a causative effect. So in other words, a very high percentage of people brux anyway, and the TMD condition was not brought on by the bruxing, so to speak. So yes, they correlate, but no, they're not causative. That's where the research is sitting right now. And so yes, there's a relationship. Yes, you can help your TMD symptoms by reducing or changing bruxing, nocturnal bruxing, if you can reduce or change it. It's a contributing factor. However, it's not the cause of TMD. So how do you deal with nocturnal bruxing? It's very, very difficult. Obviously, it's there's a psychological element, there's potentially an airway element. But because TMD is so multifactorial, there are so many things that we can address, like the daytime bruxing, and like providing exercises and education and some simple therapy, that if we can tick off enough of the other areas, often that patient will get better despite the fact they continue to nighttime bruxes. And we've seen that time and again.
Yeah, so I'm a bruxer. I've got OSA, obstructive sleep apnea. I have worn a CPAP for the past 4 or 5 years. So, and like I say, I have a history of TMD. So I'm a little bit, I don't know, would you call me stressy, Tim? A little bit anxious, a little bit, I don't sleep very well.
You're fun to travel with, Sarah.
Yeah. So I don't sleep a lot.
Technologically challenged is another.
Technologically challenged, exactly. But I'll tell you a little story. So I've had 2 really severe bouts of TMD in my life. I've had, stabbing pains and little bits and pieces along the way, which a lot of us do. A lot of us will say, no, Sarah, not you. A lot of people will say, oh yeah, I've got sore muscles in my jaw. There's a lot of that around. They're the easy cases. It's the cases like me who, have the stabbing in the ear and then start to get the neuropathic pain, and it goes on and on. On my left side, I had it for years. And of course, being in dentistry, I had everybody look at my teeth. I was blaming an old root canal that I had done 10 years ago, and I was at the point where I wanted it extracted because it was causing so much pain when I ate, and nobody could find anything, and it had become so chronic and then complex that it was causing neuropathic pain. And long story short, it turned out to be not the 2.6 at all. It was the 1.5. I had a crack right down the center of a virgin tooth from my bruxism because I hadn't had my sleep apnea diagnosed for many, many years. And so by the time I had it diagnosed, it had obviously already cracked the tooth. And just like glass, the crack just kept going down and down and down until, finally it was discovered the tooth was filled. It didn't need a root canal. It just needed to be filled. And not a day of pain since that filling was done. All that neuropathic pain that would have been treated as trigeminal neuralgia all disappeared. Now, moved forwards to the start of this year, I woke up one day with terrible pain in my 4.3. I also had some pain in a couple of molars. So I knew we were on holidays. I was different bed, different pillow. I'd been absolutely shocking with my sleep. My CPAP had been leaking for 6 months. I was a mess. I knew, I've got to change that pipe. I've got to do this. I've got to do that. I'm too busy preaching to everyone and not looking after myself. And so I woke up this one morning with these crazy sore teeth and all this muscle pain. So it all triggered off at once. Anyway, again, for months, I had to put into practice everything I knew. I had the Max Fax involved. I had the GP involved. I had a couple of TMD dentists involved. I had an orthodontist involved. I had the girls at work, the dentists at work involved. Everybody's looking at my teeth. I keep saying it's the 4.3, it's the 4.3. This one, everything else is settled down with all my physical therapy and getting my sleep right and doing all the other things. But yeah, I could just never get rid of this pain in the 4.3, which is unusual. Again, completely virgin tooth, no issues at all. I haven't had decay, since I was a child. And I had MRI, I had CBCT, I had OPG, I had everything, all the bloods done, everything. Nobody could find anything wrong. Anyway, I had a splint made as well, which made things worse. But anyway, so I went through the whole gamut of everything. And then maybe 3 weeks ago, I said to an OHT friend of mine, I said, I can't work it out. I said, either I've got some really weird tumor here or, everybody's blind or I don't know. I said, take a PA. And she took a PA and I've got an abscess there, which wouldn't have shown up possibly on all the other diagnostic x-rays, but I've ended up subsequently having to have a root canal on that 4.3 from bruxism, which became part of my whole TMD picture. Again, it triggered off neuropathic pain. I was already centrally sensitized from having the pain on the other side for so long. So yes, bruxism can be the straw that breaks the camel's back. Bruxism can contribute to TMD. Was it the cause of my TMD? No, I had all the muscular stuff and the poor sleep and the anxiety and everything else happening at the same time. But the bruxism certainly, has caused me 2 teeth issues that have been completely undiagnosed by all my colleagues, and I can't look in my own mouth, but what it yells at me is that there must be so many trigeminal neuralgia TMD mimicking trigeminal neuralgia cases out there with undiagnosed tooth pain. So we do need to take bruxism seriously. We do need to listen to these patients when they have TMD flare-ups and they're pointing to teeth, and the muscles, the muscle manipulations and the splints and everything else don't resolve that pain. Keep looking, keep looking, keep looking. Don't let them,
So you can kind of sum it up to say that bruxism caused the biological damage or the tooth damage, which set off a cascade of pain symptoms. But I can guarantee now that those teeth have been repaired for Sarah, and this is kind of the point, she still bruxes. That's the point. But she doesn't have any symptoms now. So that's the kind. I hope you can grasp that relationship. It's a little bit nuanced. Yes, bruxing is a problem, but it's not quite as simple as you brux, therefore you've got TMD. We're going to move on because we want to leave time for you guys to be able to ask some questions at the end. And so once again, the takeaway is to listen to your patient, ask lots of questions, figure out whether it's an acute joint pain, a muscular symptom, or whether there is more to it. And they're the basic questions that we touched on already. So talking about splints, and we'll just do this very briefly because it's actually not that complicated for me to summarize the research. I did my own critical literature review of 10 randomized controlled or meta-analyses. So 10 reviews, which each were meta-analyses of randomized controlled trials studying the effectiveness of splints. And so if you put all of those together, at least 10 papers in each review, and so maybe 100 studies. I can't remember the exact number, but it was a good number. And so do splints work or not? That was kind of for TMD specifically. So I'm not talking about using splints to protect your dentition. I'm not talking about using splints for other purposes. In fact, Sarah, the three purposes of splints said by a dentist, who will say it better than me.
Yeah. So in dentistry, we know there sits a lot of confusion around splints, and there's a lot of polarizing opinions on which splint is best for what. And again, I've had my own fair share of splints that I've thrown in the rubbish bin because they just haven't worked, and that always confused me. But I guess when we're looking at splints, we need to ask why. In dentistry, why use orthotics? Why use splints? Why use a nighttime or a daytime appliance to begin with? So there's a few simple reasons in dentistry that we use splints. One is for palliative care, so for pain, to get people out of pain. Two is for protective. If someone's going to do a full mouth rehab and people are worried about breaking teeth, you want to protect those teeth. And three is to just buy time to figure things out. So use it as a diagnostic tool. So I think as far as it goes, as in relation to TMD, and splints, we do look at them in certain cases, for temporary relief, and it would be short-term only. Okay, so that's the long and the short of splints used in TMD.
Yeah, the take home from the big, horrible, painful, critical literature review was that splints, yes, can assist with temporary relief. So the point is that, again, and this ties in with all that physical therapy research as well, it's no different as far as musculoskeletal pain treatment goes, is that unless you can improve function, and this goes for orthotics in shoes as well. So orthotics in shoes often do exactly the same thing. They provide temporary relief, but they don't change function. So they're an orthotic, they're like a crutch, let's say. And so they can provide temporary relief, and that's good, but normally up to 3 months and not more. And so unless you take the opportunity to use that window to give your patient functional retraining. So oromyofunctional therapy exercises are a great way to do that. Education around how much they're allowed to move their jaw, etc., some exercises. And yeah, just even education, like we were saying before, about the resting daytime state of their rear molars, as well as the fact that movement is helpful, etc. It's that functional rehab that is what will give them the long-lasting results. And there's further studies that have demonstrated clearly. Jeff Okerson has done a big one not that long ago, where he compared splints and other dental interventions for TMD compared to exercises and lifestyle changes. And they both got some outcomes, but it was only the improving the parafunctional habits and improving the function of that orofacial complex that gave long-lasting results. So so yeah, that's the long and short of it.
Yeah.
And it's exactly the same when I'm rehabilitating a lower back. It's exactly the same when I'm rehabilitating a shoulder. I can do therapy that will make the pain go away. And that's nice. That's great. But unless that person starts to load that area and rehabilitate it, then they're not going to get the pain's going to come back again.
Exactly. Can I just say, as a long time on again, off again TMD sufferer, splints are not king. Okay, splints can make things so much worse for us. So you really have to think more about, where the pain's coming from, get the diagnosis right, communicate with the patient. Communication is king, not splints. Okay.
If your patient is in this,
have that in your mind that it can make it worse.
It can, yeah. So if your patient is in this complex multifactorial, if you've asked them a bunch of questions, you've decided, yes, they have anxiety, yes, they are bruxing, yes, their sleep quality is terrible, they've just broken up with their partner, a few questions like this to get a bit of a lifestyle picture of this person. And then you may say to yourself, maybe changing the way this is sitting might be something that causes further aggravation, because I'm just going to, it's another change on top of the 12 other things that are happening in their life right now. So in some of those situations, it'll actually make their symptoms worse.
Yeah.
So let's, we're kind of out of time, and we want you guys to ask questions. So let me just touch on these last few slides. There's science to back now that your therapy, so your patient improving or getting better, is proven to be more effective when you have a good rapport with them, when you have a therapeutic alliance with them. Sarah's got lots of stories from maybe we'll have time for some of those stories from the Max Fax setting. There's also study to demonstrate that the better you listen, the better outcomes you're going to get. I mean, this might sound simple or even silly, but it really deserves stating, because too often these patients end up a long way down the line and no one's asking them the simple questions. And so in other words, you're treating the person, you're treating their lifestyle, their background, where are they at in life, what's happening right now. New patient today with ear symptoms, and they'd had a bunch of therapy, and when I asked enough questions, they've been getting their neck treated for this, which can fix there was some deafness in that ear, which can fix it. But when I asked enough questions, it unfolded that there was a bit of a TMJ history, and there was a bit of anxiety history, and just some questions like that made me go, well, the solutions are actually quite simple here. Like, I can see exactly what's going on, what's causing your symptom. It was relating to a jaw, which no one had treated yet. The practical take home that we would encourage you to tie a lot of this stuff together, especially for the patients who maybe have anxiety and that is a contributing factor, some simple homework that you can give them is to lie on a flat surface with their chin tucked down a little bit. So it's in a neutral type of posture. So that chin tucked down, that actually helps establish a good cervical lordosis, which helps cover off a lot of contributing neck factors, which can contribute to TMJ. And you get them literally to lie on a flat, firm surface. So mattress is too soft, so yoga mat or floor, in this posture with their knees bent for 10 minutes twice a day. And they use this opportunity to retrain their orofacial or orofunctional habits. So they want their tongue on the roof of their mouth, tongue on spot, lips sealed, nasal breathing, rear teeth not touching, and diaphragmatic breathing, which means they're breathing into their belly or their lower ribs, which assists in decreasing the symptoms of anxiety, decreasing sympathetic tone, and increasing parasympathetic. So getting them out of that fight or flight type of phase. It might sound really simple, and it might appear to the patient this has got nothing to do with their jaw, but it's a critical element it's a really useful and very simple homework exercise that can cover off on a whole list of contributing factors, potential contributing factors. We always prescribe this for 10 minutes twice a day for 10 days, and then just come back and tell us what, take a bit of a baseline of what their symptoms are doing, how frequently they get pain, how intense their pain is, and maybe a VAS scale, 1 out of 10 scale on their pain, where their pain is. Get them then to do this for 10 days. Maybe you don't even touch anything else. And then come back and listen to them again and retake and see if that baseline's changed. See if their frequency or intensity of symptoms has changed. And in many, many cases, you'll see that simple intervention will have changed their symptoms. So that's a simple takeaway for you out of this lecture. If you want more, if you really want to get your head around this and you want a very good problem-solving framework, the course that we've developed is available online. It's over 8 hours of training, over 50 videos. If you purchase it, it's yours to keep. You have permanent access. You don't have to pay a subscription or anything like that. It's valued at $7.95 US. Now, in the past, we have offered this course at a good discount. We don't actually do that anymore, except when we present live to a group. So a group like this, we will offer you guys only a 24-hour discount code that will give you basically a $300 credit. So if you use the code EMS when you get to the payment page for 24 hours, then you can have it cheap. So you can have it at $4.95. And so the only time we offer discounts like that, we don't kind of promote the course, advertise it out there with discounts. We did that when we first started the course a couple of years ago, but it's become really popular. It's really valuable, but we just love speaking to people. So when we get to speak to people live, we want to give you a discount for a short period of time uniquely for you. If you want to jump into the course, the best way to do it is simply go to that link, and there's lots of videos and all sorts of explanations there. So you can really have a good hard look at the content before you make a decision. I reckon.
Questions.
Yeah, love to hear questions. Tabitha.
So one of the first questions, which relates to the link for the course, some people asked if you ever run this course face-to-face as well.
We used to pre-COVID, and we may do post-COVID again, but we created it. We had requests globally for it, and we couldn't get to all the places as much as we would have loved to. So we created this to just fill a void for those people, and then COVID hit. So it's worked out well for everybody. But yeah, in future, we probably will offer it face-to-face again, but who knows when that will be.
So there's a group that we did run it live with a few years ago in Adelaide that you can see on the screen there. The thing is, to be honest, that as long as you're diligent and you actually go through the material, it's professionally filmed with close-ups and all of that kind of stuff. So it's very clear and very applicable, and you've got it to watch and rewatch.
Yeah.
And that 8-hour course, we can actually fit more content. There is more content in that than we've been able to cover in a 2-day course as well. Now, they're not the same thing, but it's valuable in that respect.
We've also had a couple of people who have come along and listened tonight want to know if they could get the links to some of the papers that you've referenced.
Absolutely, yeah. So how should I do that, Tabitha? Should I just email them to you?
Me, and we can email them out to the people registered for tonight.
Right. Yep. Oh, I should, I can probably even give you these slides. I can give you a PDF of these slides for your people. And we've got the references here.
Perfect. Thank you.
So, yeah, no problem.
So there is some questions. So we have a question here, part one of it. Is a hard click of the TMJ indicative of acute category?
Great question. No. So a hard click is common. So the most common, as you may know, the most common click in TMJ is when the disc is anteriorly displaced, and it sits permanently anteriorly displaced. And as the individual begins to open their mouth, the disc clicks back onto the condyle as they continue to open. If it's a fairly firm click, like it's still most likely the disc. If the disc is absent and it's bone on bone, it'll be crepitus. It'll be a grind. It won't actually be a click. So when it's a click, it's still the disc, and a painless click is quite common and quite normal. I don't have time now, but there are exercises that you can actually do that can reduce and even eliminate that click, even if it's been there for many years. So I've got a doctor who works in emergency who had a clicky jaw, and I gave her those exercises and a handful of treatments, and over about 3 months she eliminated the click by doing the exercises. And she would tell me, "Oh, thanks for everything you've taught me about jaw, because I had a patient in the other day with jaw problems and I knew what to be able to tell them because she'd been coming in and getting some therapy." No.
So part two of that question was then, if you've got a patient with no pain and they've got the click, do you think you should intervene or leave it?
Don't intervene.
Yeah.
If you want a really simple answer, don't intervene unless they want you to. Unless they really, really want you to, there are exercises that you can do to address the click, and that often works. They do have to do them for 3 to 6 months. They have to do them for a long period of time. And that's the simplest and best way to address it. Splints and other interventions sometimes work and sometimes don't. And if they've got no pain, I tell them that all the research says noisy joints don't matter.
And so we have another question here that says, a lady here says she remembers working with some older dentists early in her career that were very obsessed with centric alignment and rehabilitating mouths with restorative build-ups, with the opinion it established a better balance and to resolve TMD. What do you think of that?
Do you want to answer that one, Sarah?
Well, I thought we already did, but you can.
Look, that's been a common practice and a common, and look, it doesn't mean that at times that would help. Like, it may actually work to get that centric relation ideal, and especially if the dental restoration created any advance of the mandible, then it would take some, or if it built up teeth that had been worn down. So what do you call that, Sarah, that vertical height?
Vertical dimension.
Yeah, if that vertical dimension had been decreased a lot, then building up teeth could help TMJ in that respect. So there are scenarios, but broadly speaking, looking at the research, it's an old school way of thinking that is being abandoned.
Yeah.
As far as treatment for TMD goes.
Yeah.
Do you teach functional manipulation therapy in the course?
Yes, unless functional manipulation therapy is a brand product program that I don't know about. We teach functional exercises and functional soft tissue work in the course, yes.
Someone has a question here about how would you go about treating clenching during the day, and is it possible that could be contributing to migraines?
Yes, it's possible. So migraines is probably the simplest way to put it is that TMJ can be a contributing factor to migraines, but normally isn't. It's rarely the cause of migraines. And that I know that because I treat migraines and headaches all the time. And when someone presents with migraines and headaches, I will treat their cervical spine and resolve their problem 9 times out of 10. And the other 10% of the time, I need to address their maybe asymptomatic TMJ as well. to treat the migraines. But if the patient doesn't have TMJ symptoms and they do have migraines, then it's most likely their symptoms are cervicogenic, are actually the neck, most likely.
I've got
even though they daytime clench. Sarah's got some good tricks as far as good myofunctional exercises to help daytime clenches, and just that education. It just
going back to, again, educating them to be aware of when they clench, to not clench, keep the teeth apart. If your teeth are apart, you don't engage muscles. So it's just, if you've got to make them wear a rubber band around their wrist and ping themselves every time they clench, do something that starts to teach them. You can easily teach yourself out of it, depending on, what sort of anxiety and nervous disorders they have. Some people do need, a habit breaker, and you can make like 3 to 3 Essex appliances with a centric platform. There's different habit breakers that can be made for those cases, but I would say the majority of cases I've come across, just education, and particularly in an orofacial myofunctional therapy program, you're seeing them weekly or every couple of weeks. So it's just education, reminding, and that habit breaks pretty quickly and pretty easily, because a lot of the time they're just not aware that they have been closing their teeth together. So
environment is really important. Like Steve, ask them to figure out when they clench. Is it when they're concentrating, or is it when they're at work? Is it when they're in a specific environment? Because normally it'll be an anxious response to a specific environment. They won't realize until they think about it. They'll go, it's actually at this time of day when I get at work, that's when I always catch myself doing it. So therefore, I think I have a bit of a social anxiety, or I think I have a bit of a, they can often figure it out. And that's a massive.
And again, that's something that you can sit down and figure out with them. And that's why you do need to sit there and talk to them and listen to them. And it's incredible. I was sitting in a session with one of the Max Faxes recently, and this patient didn't stop talking. And I just looked at the Max Fax afterwards and I said, she gave us every single answer we needed. She told us absolutely everything. It was incredible. So listen. And obviously the longer you do this, the more you'll recognize all those nuances, and I could pluck those all out. But just start listening, and don't be scared of listening. We're healthcare professionals. Some people say, oh, don't open that can of worms. They might tell you things that you don't know how to manage. It never hurts to listen, and you'd be amazed at what they tell you and what's contributing to their TMD. And you're not a psychologist, but it might draw out that they need to go and see their GP and go and see a psychologist, or sometimes people need to have their hand held through that just to give them permission to go and seek that help. So
you can tell Sarah's on her hobby horse. She is a great listener.
We've got a lot of questions here about referring patients. So they'd like to refer to you, or how do they find someone in their area? Do you have anywhere where people can go to find people to refer to the area that they're in, or how they refer directly to you?
I work in Geelong. So Sarah and I are 2,000 kilometres apart. I'm in Geelong and Sarah's in Brisbane. And so certainly Melbourne, Geelong patients, I'm very happy to give details. Both myself and my colleagues are trained in treating a lot of TMJ. We do have a list of therapists who have done some training with us. So we have kind of a handful of therapists probably in most capitals in Australia that are good to refer to. Maybe we haven't done well enough with our database, to be honest, as far as, but if people want to reach out to us, that's absolutely fine for referral, and there's a good chance we'll be able to know someone near them. We've trained in most capital cities.
So I'm going to ask 2 more questions and then we'll wrap it up for the night. Do you see many issues with TMD in edentulous patients? I thought that was an interesting question, so I'll stop you.
I haven't. Whether they just haven't been referred to me, or whether it doesn't happen so much. I imagine edentulous patients can't exert the same degree of pressure. That's at a guess, but I don't know. I haven't really seen. I've certainly got patients who have. I've got one lady, for example, who's had an osteotomy where they had to remove part of her jaw due to one side of her jaw due to cancer, and so she has denture, and she has no jaw on one side, and so she does get a lot of asymmetry and pain in the opposite side, and the right exercises and the right treatment get rid of that pain for her. But that's a different story, I guess, that denture.
Well, and that would have been coupled with a lot of anxiety and stress along the way through all the cancer treatment, and But no,
I haven't actually seen.
No, I'm thinking the oldest one I've seen was from, he'd been to a dentist recently and been given 6 blocks, and 6 months later he was still in pain, so he was at the max fax. But otherwise, I don't know, I think maybe a lot of elderly people have so many other things, maybe they don't complain. I don't know the answer to that.
I just have another question for you now, Sarah. This is an interesting one. As an OHT, can we perform these exercises for our patients, or we need to practice under our OMT hat?
Well, the great thing was, when I was on my journey trying to find techniques that I could incorporate into my myofunctional therapy, they're actually techniques that you can incorporate into a dental exam. So when I'm performing my dental examination and I'm doing the extra oral examination, I will palpate the muscles, but the technique that Tim has taught me, you palpate and treat at the same time. So I've not yet to date had one person. It's super quick, and it literally does feel like palpating. So and I'm asking them, do you feel any? I mean, I've done it to you, Tabitha, but you were sensitive. But normally, you can go through it and do the palpations, and people will say, no, there's nothing there. Oh, that feels really nice. And so you can assess them pretty quickly. And I've not yet had one person. I always give them permission, to stop me at any stage. It causes no harm. It's helpful. It's caring. It sits them in a nice space to just have a dental exam. So,